Hi, my name is Cindy Bradley. I'm the chair of the INACSL Regulatory Initiatives Committee, and based on the work of that committee, we are publishing an article that summarizes the documented regulation data gathered within the United States for how simulation is being used in nursing education. So the purpose of this presentation is to give an overview of the data that was collected. Simulation use has increased in nursing education as an alternative method for providing direct patient care learning experiences. The reasons have been well documented in the literature, some of which include promoting patient safety in tandem with decreasing opportunities for direct patient clinical learning encounters. Because of this, nursing programs are seeking how to integrate simulation in the curriculum to either augment or to replace clinical hours. The National Council conducted a national simulation study that provided the evidence that up to 50% of clinical hours can be substituted with simulation with no differences in student knowledge and skills. Following this study, the NCSBN developed guidelines to assist the state boards of nursing in developing regulations for the use of simulation in nursing education. In doing so, the National Council also recognizes the legal jurisdiction of each board of nursing, since all licensure is regulated at the state level. The INACSL Board of Directors formed the INACSL Regulatory Initiatives Committee to compile simulation regulation data both nationally and internationally. As the chair of this committee, we first began with a national search within the 50 United States and the District of Columbia. As a committee, we divided the states between us, and we began to contact each state board by phone and by email, and we decided on specific data that we wanted to collect. This included only documented data of the date of established simulation regulations, the percentage of clinical hours that could be replaced with simulation, the ratio of sim to clinical hours, a definition of simulation, and any requirements of educators facilitating simulation. What we found is that 30 boards of nursing had publicly documented regulation. Simulation was defined by only 23 of these states. It's important moving forward that we are all consistently defining what constitutes simulation learning. Of the 30 states that had documented regulations, 25 defined a percentage of clinical hours that could be replaced with simulation. 13 states allow up to 50% replacement of clinical hours, and 9 state boards allow up to 25 or 30% replacement. 4 other states identified regulations for replacing clinical hours, but did not specify an exact allowable percentage. There were also states that had percentages for clinical hours only within specific classes. Most often, these were for pediatric and OB clinical courses. In regard to the ratio of simulation hours that are counted as equivalent to traditional clinical hours, only 3 state boards addressed this, and all 3 identified a 1-to-1 ratio. 1 state allowed either a 1-to-1 or a 1-to-2, but only if the program was nationally accredited. 25 states did not define an equivalence ratio between sim and clinical hours. 20 boards did describe requirements for instructors who participate in simulation. These requirements varied widely. Some boards referred to the INACSL Standards of Best Practice and the NCSBN guidelines as the criteria for preparing educators. Some states were specific in the requirements and also used language consistent with the standards. What was not found were specific criteria of how to achieve this or how to measure the outcome of training. It is important to note the states that do not have any documented simulation regulations as well. Finding the documented board regulations was difficult for some states. The data included in our report was only documented data that was publicly accessible. We heard many anecdotal reports from educators within various states, or even from the offices of the state boards themselves. We also read through pages of minutes of board meetings, but the data included is only what was documented as regulation for nursing programs within those respective states. We also found that communication of these regulations varied widely between the states. This also includes communication of any new regulations and also updates to the regulations. The question that is most often asked in regard to regulations is what percentage of the clinical hours can be replaced or substituted with simulation. So this means that we need to know the clinical hour requirement for each state. But because nursing licensure is regulated at a state level, there's wide variability between the states regarding the minimum number of clinical hours. Some states do not set a minimum number of clinical hours, but for the states that do, the range of clinical hours is wide, 432 to 960 hours across the states. This makes the percentage of clinical hours ambiguous. 50% of 432 hours is far different than 50% of 960 hours. So perhaps the question we now ask may shift away merely from the quantity we can replace as we focus on adhering to similar methodology of the National SIM study. Training for faculty is a must. If we look at the training that was included in the National SIM study and we want to achieve the same results, then we need to train faculty similarly. But without guidance and requirements at the state board level for training, faculty may not receive the training they need to facilitate high-quality simulations. In conclusion, this is a summary of the documented regulation data collected from the United States Boards of Nursing. This article should be available online in the Clinical Simulation for Nursing Journal later this summer, so I hope you will read this and act accordingly. Thank you so much for your time.